Let's see if we can do it today. Looks like we got it. We're back. So we had a little bit of hiatus, kind of unintentionally. So last week we had a tough internet signal out of town, but hopefully this week we're kind of back in the home stadium and we'll make it work here. So if you can, good evening, good to see you. Would you mind just saying hello in the chat so I can see that it's working? And then we'll rock and roll from there. Susan, hello. Wonderful to see you this evening. Fairzuck, it's late. Scolding, but I'm glad you're here. Karma, hello. Nice to see you. Okay, looks like we're going. All right. And we've got... Oh, there they go. They just came through in a bunch. We got... we got a Canadian. Dennis, hello. The Good Brain. Oh, we got a little name change. Sherry Butts. Fairzuck's going to bed. Okay. Well, if you watch tomorrow, I'll expect you to take notes right after Martin's done. So let me know how that goes. We'll talk to you then. Okay. Missed the last live stream. How was it? Well, the last live stream, let me tell you about it. Mary, home with Sidney Crosby, love it. So last week, I had this nice presentation all prepped out. I made slides, did all sorts of things, and then my internet just couldn't keep up. We were just too good. It's too hot, couldn't keep it. So I made a quick video, also a little fuzzy, just kind of going through that slide process. We talked about this one right here. It was this this study that I thought was worth digging in on. Big Erm's talking about it right now. Anecdotally, I've tried IV at a local beauty bar kind of place, and that the Myers cocktails weren't particularly effective. Nor has the regular saline been that effective. Yeah, Michelle says hello as well. Matheson, what's up? Yeah, that's the whole. So Matheson, we'll get through this, but yeah. So what we're trying to do here is we're going to take a little moment to tell a story. Why? Because it's Thursday and it's great, and we're letting everybody come. Yeah, so we started to talk about IV solutions. I did a video on it last week. I'm going to go briefly through it today, and then we'll talk about it because I think it's important. It's kind of like if you're thinking about volume as being a problem, whether you understand that as an absolute volume or a relative volume, that becomes the really big question. And I think it's worth kind of digging into because it'll help us be able to see the picture a little more clearly. And what I was saying is, yeah, I think about YouTube and I think about social media as a way to create a library of the conversations that we have in the clinic. And what I noticed was before I started doing this, I was a little ornery, and I used to complain about the things that people would say about treatments and about like the way they thought about some of these problems. And I would complain that I thought maybe they were perhaps not the most useful way to think about it. That's using the nicest language. And then I had a wonderful friend tell me, you can't complain about it if you're not going to do anything about it. And I thought, oh, you are right. So that's what we're here doing. And the reason I think the kind of the thing we set out to do is say, okay, well, we have to try to introduce new ideas that help us be able to like spark a little idea and ask new questions. And then those new questions help to fill it out. And then we can introduce a new thing and then new questions and fill that out. So we're trying to like give an idea, respond to the questions, give an idea, respond to the questions. And that helps us kind of build out an understanding of what we're thinking about in terms of neurological health, autonomic health, health in general. We're just trying to help people live a healthier life. So that's kind of what we're doing. And putting it here lets it be here for as long as we leave it up. So it gives people a library to come back to, so they can kind of see what we're talking about. So here we go. Yeah, I did see the newly discovered genetic correlations. So somebody brought this up a couple weeks ago, but when you look at these, so like epigenetics are become important, and then the other key part here is differentiating between what we think about as like DNA genetics versus things that it's a little bit different, looking at mitochondrial DNA. So making that separation is actually really important. I'm glad that we have this study. We can talk about that one later, but I don't find that one to be as valuable in terms of it being actionable, if that makes sense. So we'll try to use some things here that are actionable for people and keep them rolling. Cool. So just to catch up in the chat real quick. Eileen, tell Bodyguard I say hello. We got to be getting into to like peak. You guys got fruit season up there? Are we just in the fields? Are we cutting? What's going on? Love to know. We just found we're getting real close. The neighbor here has a wonderful peach tree that is just dying for my kiddos to get climbing in it. So they're almost ready. It's an exciting time of year. Fairzuck's portfolio is rocking. Just short and healthcare stocks. I love it. Keep it going. Oh, I love the hair look. So another aside, we'll get into some real content, I promise. I actually took my son to the barber last week or 2 weeks ago, get ready for school. I sat down in the chair and I said, I finally got it to lay down on my head. And they were like, you probably shouldn't get it cut yet. So here we are. Still haven't gotten it cut. Okay. Fatima says, hello. Hola, Melissa. Let's see. Josh, back to school. Ooh, love it. All the nerves, ready to rock and roll. Josh is super smart, by the way. Anybody gets a chance to talk to that fella. Smart, smart, smart people. Bubby's here. Cheryl's here. Corden coming long down. I don't know. Yeah, Matheson's kind of going to make a point here, and then we'll say hello to Irene, and then we will get into our content for today. So, but I think it's worth it. Isn't it kind of working in two contradictory directions when conventional docs on one hand go, let's pump up the patient's blood or fluid volume to see if they feel better, and on the other hand go, let's give them beta blockers and lower their blood pressure to see if they feel better? I mean, I get what they're thinking, and they're not thinking about the flow to the head separately from the rest of the body, it seems. That's kind of my perspective as well, is sometimes, so we're trying, anybody in healthcare is trying to help, right? And that's the purpose. And regardless of what the incentives are, and kind of if you go down that road or whatever, that is what it is. But everybody's trying to help. So if you're somebody that's, having a really hard time with symptoms that are related to your heart rate being up, and your Rolodex is like, I've been spending my whole life thinking about chemistry and how I can manipulate chemistry to change functionality in people, then that's what you're going to do, right? So, that's just kind of the nature of it. And we're going to say fluid volume low. We don't actually know fluid volume's low. We know that relatively it's not getting against gravity very well. So maybe we boost it up, right? Or maybe we slow the heart down, which is going to have the opposite effect, but it may make you feel a little less anxious, a little less jittery, a little, less tremory, a little less palpitations, right? But what you're looking at is like, a lot of those problems are more related to, as I'm trying to crank up and solve this blood flow problem in my head, unfortunately, some of the bleed off is that we're going to get symptoms that look like kind of that like panicky, anxious, I can't breathe, my chest is crawling, it's tight, I'm shaky, all of those types of symptoms. So I think you and I are speaking the same language there. But what we want to do is see, can we articulate this in a way that it makes a lot of sense for people so that we can start thinking about it differently and then give people some new options for how to pursue this. Because as you know, probably everybody on this stream did not start out as waking up one day and be like, you know what, I'm going to try to have to become an amateur expert in autonomic systems so that I can solve this problem. So most of you are like catching up on the fly. That wasn't the goal. That wasn't the plan. But here we are. So can we make it easier? Can we onboard people into like thinking through these processes a little faster? Cool. All right. Let's rock and roll. Okay. So let's pop this up. This is what we are going to talk about last week. I did make a video on it if you want to go back and look at it. It's in a long form video and I just ran through. But basically we took this paper that just came out, I think it was in July, late July. And they were looking at IV saline in people that have ME/CFS, which is like, you know, kind of adjacent to what we look at with POTS, right? Let me see if I can control this a little better. Hold on one moment. Just trying to find my presentation here. Had it all up and running. It was ready to rock, and now look at us go. Anyway, so there's an overlap when you look at ME/CFS, especially we talked about a couple weeks ago in this land of cerebral hypoperfusion, right? We have a crazy high percentage of people with ME/CFS that struggle with cerebral hypoperfusion as measured by transcranial Doppler on a tilt. And that happens to also be related to kind of what a lot of POTS people feel and get diagnosed with as well. Again, the hypoperfusion on a tilt. And then we also see the correlation that comes from low levels of circulating carbon dioxide, also known as hypocapnia, which can lead to its own types of problems with number one, acid-base balance, but then also in cerebral blood flow as well. So you kind of see this overlap. That's why we're talking about ME/CFS. There's a lot of overlap with POTS, to be honest with you, from both a objective and subjective component. Objective meaning like things we test that we look at with physiology, and also things that people experience as far as symptoms go. So that's the overlap here. So they're taking some information from some previous studies that looked at that looked at a couple different autonomic variables. There were a bunch of other studies that have been done in the past. We've actually got a white paper that's coming out. I have some white papers written. We're trying to figure out where to publish them, if we're going to do it on the website or in a Substack or something like that. Maybe if you guys have some feedback there, you could let me know. Right now my Keynote is just spinning, so I can't change the page if you're wondering why we're stuck here. Okay, so I'll just go forward with it. You can see in the language of this paper, it's pretty cool. They're saying beneficial effects, there's my pinwheel, beneficial effects of intermittent intravenous saline infusion. So right in the title of the article, they're saying like it's a benefit. It's a case series here. It's good work. It's a good team. Really happy that they did the work. Let me see if I can get out of this thing real quick because I want to show you. Let me put it on this one, and then we'll just like a hard shut off on the Keynote here. Let's see if we can get it back. Anyway, super good research group. Beneficial effects. They were noticing that they chose to measure a few things. And when you plot them in a certain way, let's pull this back up here. There we go. When you plot them in a certain way, it kind of makes it look like when you do kind of these different, what would you call these? These are just different quality of life indices where you're asking questions, surveys. And, you know, if you look at them here, it's like, hey, the POTS score went down a little bit. Looks like their quality of life maybe went up a little bit, their working ability. But some of these, you're lumping them together. First of all, you started with a super high, like you had whatever it was, 40 people initially in the paper. And then you end up kind of somewhere closer to 17 that actually go through the tilt test at the end. Let me see here. Back up. Yeah, so 22 completed. They did it every 3 weeks, and they had 40 people start out. 22 of them completed all 3 infusions. And then 19 out of the 22 finished the questionnaires, and then 17 did all 3 of the questionnaires. So it's kind of a small group. And one of the things that we pointed at, that we were like, oh man, that doesn't look good, was looking at these scores. Normally the way that you would do this would not be in this composite scoring, because you only have 17 people. So if you got 17 people, you don't have to draw them up like this, and it's only 3 plots. So it's like, here's how they did after the first one, or here's what their baseline was. Here's how they did after the first one, the second one, the third one, and then you probably would do follow-ups like 2 weeks later, 4 weeks later, 6 weeks later, whatever. But this is just like a sampling study. They're just trying to like see if there's something here. And it does that for me because this study has been done before. So it's not like they're trying something brand new, but they're just kind of testing like what their protocol is. Anyway, and you can see the composite symptoms seems to, kind of like trend down if you add them all up. Now, but with 17 people, you would want to actually look at them all individually. They call it a spaghetti plot, but you look at each one individually, and then you can see how are they tracking over time. And you want to see, is it a consistent trend down? Does it move around? Is it variable? Does everybody kind of look the same, or are there ones that respond real well, and then there's others that don't respond as well? And then, so like that data is really useful, because then you can say, you know what, like maybe only 4 people really responded great, but they responded great. And then we go, what is unique about those people? And then we have a study there that lets us go, well, this type of person does respond really well. When we look at these other ones, they may not. So the way that they lump this together is to kind of show an effect. Take that for what it is. I mean, they're just, just putting it together. Anyway, so looking at it, they post some of this stuff kind of weird, because like the working ability is based on 100% score. I went over this in the other video. And it's some of these things are just kind of arbitrary, because it's like, at what point is that, like, what does this mean to people? If you get to 85, which is like 100 here on the working ability is like you can go back to work. And you can see here that we had apparently one person at least that was able to work, and then afterwards we don't have any. So that doesn't necessarily look that great, even though this overall number appears to go up from a median perspective. But so the whisker plot might not be the best way to look at this one here. And then also it's like, this is a tough analysis, because how do you really measure from where you are to like work? It's hard to interpret, like, when are you ready to go back to work? Most of the people that have been here know, like, that's a super hard thing to know. A lot of times you just you're starting back, not feeling good, hoping that by working you can start to build some stamina again. So it's a tough way to look at it. Anyway, but the part that I really wanted to speak to the most was this, because during the perfusion itself, or during the infusion itself, you can see that the heart rate did drop during the infusion, which is pretty cool. Now, we're putting about 1.5 liters of fluid in. I don't know how much you guys remember from science class, but there's about 5 liters of blood circulating in a human. So you're adding back in like 1/3 of the volume, which is quite a bit of blood volume. So you're really expanding the overall volume. But by doing that, you're able to drop the heart rate back to our normal, which is cool. So you're saying, if we get rid of all of the systems that are in charge of accurately flowing blood around the body, right? If those don't work, and we just fill up all the reservoirs, do they operate better? And the answer seems to be that it does seem to affect at least the heart rate, which is cool, right? Blood pressure unchanged, hydration unchanged, but this is kind of not the best way to measure it. Now, the tilt test, when you're looking at this one, unfortunately, they did the tilt. They had one test that was done like a long time before they did this study. And then they did another one again a couple weeks later, like around about 9-ish days on average within 2 weeks. And what they actually found was the heart rate had gone up, slightly. But again, this is a thing where we're compiling and making an average of everyone. The more useful way to look at this would be individual by individual and see how does each person respond. You're going to get more insight out of that. But so the bummer on this one was that people seem like they're feeling a little bit better, but unfortunately, it didn't change long term what the measurements were, like the underlying problem. It didn't seem to make a huge difference on that. And then as far as like, hey, would you want to keep doing this free saline game every 3 weeks? People we kind of had a mixed bag of benefits here. People, like 42% of people said they'd continue. So out of 17, 53% were unsure, 5% said no. But then we also already had more than half, or about half of the group kind of say no because they didn't finish 3 saline. And if you guys have done saline before, it's not that crazy. You just kind of go and sit there with the bag and then leave. So not super, super hard. They did a PEM score. This is hard because people in rough shape, like they're going to get PEM from most things they're doing because they're coming from such a low base, which is a tougher measurement, but it's worth noting for sure. Let's go forward here. So just like the simple way, we got some subjective improvement, which is cool. So during the IV saline, people seem to feel a little bit better. So if you expand that blood volume and you basically take the pressure off the brain and the nervous system and the cardiovascular system, if you say like, don't worry about managing blood right now, we got you, then it helps give some relief, which is pretty cool. But the objective markers didn't maintain, so we're just kind of seeing that big short-term shift that'll last, kind of on the order of like hours, days, maybe a couple days, and then kind of wear off. And then that points to the thing, though, that I actually think is the silver lining here, which is that it kind of reinforces the idea that like this neural circuitry part really matters. Right? So you can fill all the vasculature up with fluid and people do a little bit better. But if you take it away, they don't do as well. So there's this control system that has to be functional in order for people to be able to kind of maintain that. In other words, to get up and walk around with it, to be able to walk around with that fluid accumulation, you have to be able to manage it. And to be able to manage it, the sensors have to work. The interpretation has to work in the brain, and the brain has to be able to do the right reflex on the other side. And it kind of is further support that's probably where we really, really need to keep looking. I observe that every day, so it's really easy for me to say that. But in terms of what we're looking at from a research side, it would be really awesome to see things starting to steer in that direction and correlate that with what we're seeing in the clinical setting and looking at that as a bedside. So I'm super thankful that people do this work, because it's hard to be clinical and write research at the same time. So I'm super thankful that people do this, and then hopefully we can keep evolving these in a way that keeps pushing people in the right direction. And that's kind of where we leave off here. So it's feasible, short-term benefit. We get some subjective improvement, but it's not, a reversal of physiology, but it can help us move again toward understanding like we probably need to be looking at this in terms of the control systems more so than purely volume expansion, which kind of also speaks to salt water and kind of some of the other mechanisms that are done to try to expand the volume. This is like the best, like the most focused way to expand the volume, and you're seeing the effect of that play out. So that's what we have. So let me back out of that. That's a short version of it. I see a lot of fun stuff here. I'm just going to read it real quick. Okay. I'm reading all these. I may not respond to all of them, but I'm seeing you all. Ray says all saline. Yeah, this is salted. I think this is more my issue. Chronic hyperventilation, hypocapnia, baroreceptor issues versus having POTS. Absolutely. POTS is just like one classification of how people get there. We see lots of people that don't qualify for POTS, but also have baroreceptor problems or have cardiovascular problems, breathing problems, etc. John Chung, good to see you. Yeah, there's a big dropout. As I'm sure on that study they were just like, oh man, because it really is a punch to the numbers at the end. Melissa, thanks for continuing these. Can it present as nocturnal hypotension in dysautonomia cases? Yeah, we can see that. We'll come back to that because that's a good question. Volume expansion drugs like fludrocortisone exhibit a similar effect. That's kind of that's the underlying thesis. Is like there was a published paper a long time ago that was kind of like, hey, in these paroxysmal cases where people have tachycardia, we don't know what to do. We give them fluid expansion, and then their symptoms go away, and then we kick them out of the ER, right? So there's not a follow up to that. So people are like, well, expand the volume. Okay, how do we know how to do that? We know in heart disease that if we give people a lot of salt, their blood pressure goes up. Well, maybe we just try to like do blood pressure go up scenario here. So that's why that happens. And then fludrocortisone acts as a way to maintain volume and say like, well, okay, maybe we just do it low grade over a long time and that will do it as well. And that's kind of the role that fludrocortisone plays. To a degree that's useful is probably dependent on how much somebody's kidneys keep up, how well that particular volume expander works in that person. But we will see a lot of times where it may give you some respite, but then you're going to be limited. There's a give and take. So there will be limitations in some ways, but it may be enough to take the edge off for people, which can give you a lot of respite. I want to make sure I'm delineating the two features here, right? So when you don't feel well, relief is amazing. So anything that gives you relief is still fair game, right? Because it's good to just not feel bad. So from that perspective, some of these things that provide relief, I'm here for. Like I understand, I'm not critical of that. Go for it. I mean, you get a bad enough headache, you got a bad enough hangover, and you know you can solve that with a Motrin, live to fight another day. That's kind of where people are at. Where I'm kind of standing in front of it is more in the argument of this should be the full solution, saying like these things that provide temporary relief are the long-term game plan. So that I don't like as much because then we put people in a position where we're just now relying on these Band-Aids for a long time. Most of the people that are in this particular cohort are relatively young. So we run into issues where like, how long are we going to play this game? And so what I'm advocating for is I'm okay with some of these relief mechanisms. But what I really get excited about is if we can leverage that relief into doing something that solves a problem over a longer time horizon so that we can get past it rather than just kind of cycling through these different medication theses. And so that's my perspective. So I am not talking down to anyone that uses these things. I understand relief very, very well. That is not this conversation. That's not any conversation, but it probably bears saying again. I don't mind that. But what I would love to do is say, we've got this window of time where we can buy some relief. What can we do alongside of that to see if we can push people forward and push them up out of the trap? Okay. Got diagnosis. I have severe hypoperfusion. Wondering about IV saline. How do IV saline impact someone with high blood pressure? Well, that makes it tougher, doesn't it? So if we're giving IV saline to someone with higher blood pressure, that may not be the right tool for the job. It may mean that you need to look a little bit more at like some more causality underneath it, and like what would be causing your blood pressure to go high. How do we walk that back would probably be really helpful. Elisa, 2 IVs in the last month, no difference in symptoms or blood pressure. So this becomes a control system error. To what extent do you think fluid shifts during the night cause increased symptoms in the morning? Is elevating the head of the bed reasonable or another Band-Aid approach? Good question. So for those of you that don't know, raising the head of the bed, that's been in the quiver. That's been an arrow in the quiver for quite a while, looking at anything that's related to blood volume. Because having your head a little bit higher puts a little bit of tension on your kidneys to allow them to retain more fluid. So it kind of forces you to retain more fluid, which can be useful for obvious reasons, right? So head of the bed going up a few inches has been kind of a pretty easy thing to do. Not much downside unless you got a partner laying next to you that doesn't like sliding to the foot of the bed. That makes it a little bit tougher. But it's reasonable. To call it a Band-Aid, it's not. It's a training event. Like, it trains your kidneys in that particular scenario, and then you'd probably look at what comes alongside of it. I don't know. It's a standalone tool, maybe we could say. So I wouldn't put it in maybe in Band-Aid category, but I would not put it in standalone category either. So we call it maybe an adjunct type of a tool that is like alongside of other stuff. It can be useful. So yeah, I wouldn't speak poorly of that, especially if you can tolerate it. It isn't bad. It allows you to be able to hang on to a little bit of fluid. Works the system toward pushing it back up higher, and it can actually be a useful tool, not just at bedtime, but actually starting to train the system to be able to push the blood uphill. Ray, what's the difference of getting a salt in an IV versus salt in a drink or in the food? It's just going straight into the vasculature, so it's not going through the digestive system, so it's not being absorbed. It's just like straight in, main line. Is there merely a correlation between ME and cerebral hypoperfusion, or is the cerebral hypoperfusion actually what's causing it? Well, that's the question, isn't it? So those two things probably are correlates. And then the question would then be, well, why is the cerebral hypoperfusion there? And then working that back out in terms of, is this remember a couple of lives ago, we talked about in COVID cases where we were seeing the inflammation of the inside of the blood vessels in the brain. And it was causing problems with the ability of the endothelial cells to do their job. And part of their job is they're releasing certain factors like little chemicals. Part of it is that they're detecting stretch, they're detecting CO2. And so when we get injury to that interior lining of that vessel, then it starts to affect that. And so one of the things that we see is there may be different reasons that it happens, but one thing that's common is that cerebral autoregulation can become really problematic in a large cohort of people. And in that world, then we're seeing this kind of like thing that's been dubbed endothelial dysfunction can have this sort of layered effect where it affects cerebral blood flow, and then it may also affect other components of how that endothelial system is able to operate. So there may be a little kind of underlying issue in that physiology, but it could also be in other things. We see changes in outputs of medullary centers where we see kind of swelling of the adrenal medulla. Swelling of the lower medulla in people that have ME/CFS as well. So you can see that it may not be 1-to-1 ratio, but that's a very good question. Ray, what is PEM? I'm sorry, that's post-exertional malaise. So I work out or I do something, I'm okay, but then afterwards, blah, I tank. That's kind of the generalized definition there. Yeah, Melissa's noticed that squats and lunges help a lot. And in that particular case, it works better than medication compression IV when you can do it. Absolutely. And so another component that is rarely talked about in the literature, but is very common in the cases that I observe, is where we see actually errors in sensation in the body. So not being able to actually activate the sensors that talk to your brain to tell you about certain body parts. And when that happens, then we're going to see problems with being able to supply those areas with blood, to be able to manage the return of blood, to be able to manage the sensation. That's where we can also see this, different types of overlays with dizziness or feeling anxious or feeling, kind of outside of their body because they don't feel those parts. So this is a separate area where we look at neglect syndromes that also have a high correlation with these problems as well. So activating those body parts and being able to represent them in your brain can have a huge effect on the ability to get the vasculature that's supplied in those areas to work again. What does that mean? So like if, for example, I don't feel where my arm is in space very well. I'm choosing arm because you can see it on camera. Normally, it tends to actually be more in the leg. But if I can't feel my arm very well, and those sensors don't work very well at talking to my brain, everything that brain is in charge of is going to be like, what's up? So motor coordination will be off. My ability to feel will be off, but also my ability to control vasculature, to control temperature, to control, the integrity of the skin, all these things will start to be impaired. And what can happen, especially if this is occurring in the leg, is that we actually start to see pooling in the leg because we don't see good return of the muscles coming back up. And then we see a separate category of people that deal with problems that are related to these neglect syndromes. So something we don't talk about. We should probably do a video just about that as well. Okay. This is a good question from Nicholas. It's kind of on topic here. We talked about pushing ourselves to maintain capacity in life on one end. But does this contradict doing small stimulus related to neuro rehab, trying to figure this out before school starts? So what I talk about a lot of times is people if I can't give them specific guidance, the general guidance that I will give is try to maintain your level of output the best you can. It's not a full-scale solution, because if you could just do that and it would fix everything, then you wouldn't need to see me. I'd just say, go work hard. But in the case where we know what type of problem we're trying to solve, that will shift gears into focusing on how do we give the minimal effective dose to build that specific area back up. And that may mean that we don't push super hard in trying to globally stimulate the system, but we actually take our budget of energy and we focus it just into this one area. So that tension between pushing capacity globally and trying to build a territory of function, like we're trying to do a carve out and improve that one area, those are actually probably two different concepts. One would be like in a global sense, if all I have is to give you like global suggestions, that would be the answer. But if I have the ability to be more tactical, then I will choose to do that. And I will try to focus as much energy as possible on trying to push into building out that one core area that's most likely to have the biggest expansion of function. So, good question. Okay. Fullness in the blood through IV or through a J-tube. J-tube is a feeding tube where you could also give it, but these are mostly through IV in this particular study. Susan B is asking about how changes in abdominal pressure can affect POTS. It depends on if there's, this is a good question. So if you've got something that's constrictive in the abdomen, then you want to know, is it constrictive going down or constrictive coming up, which may cause changes in the tension between the vascular system. Remember, we got arteries going down, veins coming back up. The interesting part of that is like which side of that equation is being affected. So if we're not able to push blood down, we'll feel more palpitations, we'll feel more pressure. It's harder on the system. But if we're not able to return blood as well, then we'll feel more of the pooling sensation in the legs, difficulty being able to move, heavier sensation in the legs, etc. Okay. Yeah, relief is fair game. For sure. Like sometimes I'm very vigilant about thinking about, I want to solve the problem, right? And then if I'm not careful with that, then it'll look like I'm antagonistic to anything that gives relief. And if you're someone that is like using that relief aspect, then it can make you feel like I'm like you and I aren't on the same page. That's not true. I want to make sure that people understand that as like, we'll use relief however we can, but mostly to try to leverage it to be able to do more with people. So when we think about medications, we think about why are we on it? What problem are we trying to solve? What type of relief are we aiming for? And then from that, we say, what are we going to run alongside of that so that we can try to work our way through it? So like, How do we get through this mud puddle? And then, is there an off ramp to these, or are there things that we have to consider as you come off, both from a neuro rehab perspective and a lifestyle perspective, all these things. So there should be like an on ramp and an off ramp. It's a little bit more scary when there's just an on ramp without a consideration for what are we going to do to try to then get off of these things. And I think that question is a pretty fundamental one, because it can get skipped. And so if you are, if you're at the stage of the game where you're looking at medications, that might be part of your calculus, is considering asking, like, okay, what does going on it look like? Why are we going on it? What are we hoping to solve? How can we measure that? And then what does the off ramp look like? So what are we going to do alongside of this to try to work so I don't need it anymore? And I think with that understanding, you actually get a long way with your medical provider. So if that's where you are in the conversation, I hope that's useful for you. Megan, is there a reason why the POTS community has such a focus on salt loading, but now the conversation seems to have shifted from sodium to potassium instead? I don't know. Somebody had a new product probably. Actually, there's actually regulation to potassium supplementation. If you ever go look at it, there's a maximum dose you can put in, because if you go too heavy on potassium, you can actually screw up your heart, get arrhythmias, cause some potentially acute problems. I would actually not look at it in terms of sodium or potassium, and look at it, if you're going to modulate these things, I would actually probably step back and look at what is your normal drinking water look like, the water you're drinking every day. What sort of concentration is it getting? Then consider using mineralization to support that, like a broad spectrum trace mineral, or even using, so I had, shout out to Dr. Mike Abatinozzi from when I was in school. He taught us about kind of doing this in a more natural way before it was ever in vogue. What he used to do was he would get the big glass jars and fill them with spring water. So we'd go, like we were in Georgia, so we'd go to the spring, you would get this water from the spring, and then what you do is you'd put it outside, cover it so the bugs don't get in, and then you put Celtic salt in it and let it dissolve, and you put it in and let it dissolve out in the sun until there's no more Celtic salt in the bottom, and then he would use that, and then he would dilute that back to another jar of water. So he would use that as like an electrolytic balance, because you were able to use the salt minerals along with the sun to be able to activate the ions. And that always stuck with me as a super good tool. We actually do that out here with the water that we use at the house from the well. So might be a deeper way to think about it. You can look that up. Look up Celtic salt, sunlight, water. I don't know. Somebody's probably branded it, selling you a course on how to do it, whatever. But that can be a really useful tool as well, and it gives you a more broad spectrum of that mineralization rather than just those two particular ions. If there's an area of the brain that's weak and unable to make a demand for enough blood flow, is it weak because of the lack of blood flow in the first place? Or what does it even mean that it's weak? Like, what's going on materially speaking? Is a broken connection doing an injury? I don't always understand the connection between function and physical matter in these cases. Yep, it's not always the same. So you can think about it in more than one way. So there are parts of the brain that may not being irrigated correctly or effectively, and then we'll see an overall drop in functionality there, right? And then that drop in functionality is then going to manifest as like a problem in the body with whatever that portion controls. Where it becomes difficult for a lot of people is usually those centers, those higher centers are going to feed back into lower centers, but also it's hard to generalize this, but in certain cases, there are problems that are going to be more related to lower areas in the brain that are responsible for reflexes. These simple cardiovascular reflexes, you don't have to think about them, but they just are on a loop and they keep going and going and going, and they're rocking and rolling. Now, if that loop gets affected, then it's kind of affect everything else. And then, so we see symptoms that show up that look like problems in areas of the brain, but they may actually just be because we're not getting blood flow to that area, right? So that's kind of one style. And the other can be because we're not getting blood flow in, we can't get things amplified going enough to then be able to support the reflexes, and we see errors in the way that the brain modulates the reflexes. So it's actually pretty nuanced. So from a provider perspective, that's a lot of what I teach about, is how do you navigate that question of, you can't just apply a broad treatment plan. You have to look at where it's actually breaking down. And it can be in different loops within those reflexes. It can be in different sides of the system, because we know it's a split neuraxis. There's a left and a right side. We have top-down controls that influence how reflexes work, but then we have reflexes that are going to support activity of the higher centers as well. And then you have peripheral nerves and all of the other fun stuff that goes with it, and all the integration centers. So that part is where it becomes more complex. That's where people kind of really digging in and making this a decades-long passion project is helpful for people that need some help. Cool. Okay. Yeah, so SD's just talking about balanced electrolytes, lactated ringers. Yeah, these are what they'll give in the hospital. This is why a lot of it, like you look at most water that you'd filter from the river comes through the rocks and the sand and gets mineralized and all the good stuff to that. Okay. Any thoughts on low levels of CO2 on the blood tests? Can that be related? So hypocapnia is a big part of what we talked about with myalgia encephalitis and chronic fatigue syndrome, but it's also a big component of what we see with cerebral hypoperfusion, hypocapnias, that tend to correlate with problems that are related to autonomic symptoms, right? So what we're oftentimes trying to do is get a minute-by-minute gauge of what's happening with CO2. That's why we use the end tidal version, because we can detect it in the breath. It's a lot more accessible. When you're looking at it on blood test, though, you're looking for the same thing. The breathing component is a proxy of what's happening in the blood. So if we see them low on the bloods, a lot of times they get looked over, but to me, they're pretty important and a thing worth checking and rechecking as a useful tool. And you'll compare that against partial pressure oxygen. You'll look at this against your electrolyte profile. You can look at kind of the bicarbonate ratios and start to figure out like what's going on with the pH, just doing a simple pH blood panel, and that can be helpful. Nomad over normal. Hello. Why might the brain's ability to get oxygen change while sleeping? Good question. And this is the kind of the fundamental apnea question, right? So while you're sleeping, most people that go in for a sleep study, they're looking for apnea, which is not getting oxygen in. Like the apnea is like not breathing. So the question is it obstructive? Meaning, is there something blocking? Like as you're sleeping, you have your mouth open, and maybe you're someone that's carrying a little extra weight. It's weighing on your throat and you're snoring and it's blocking or obstructing. Or maybe you've got weakness in the palate and we're seeing that palate's dropping too low and you're not able to effectively breathe. So these would be obstructive types of sleep apneas. But then you get central types of sleep apneas as well. And in central sleep apnea, you're going to have problems with the rhythm of your breathing. We'll go a little into some science here, but there's the apneustic and the pneumotactic centers in the brain, or the central respiratory generators, that keep a pace of breathing going. And it does that by sampling the tension in your lungs, oxygen sensors that we have, CO2 sensors that we have, and that help us to be able to pick a breathing rate that supports keeping all of those things in a tight range, in balance, as you might say. But if that central system has a problem in it, then we can see errors in the way that you will breathe. So you're breathing, this is where people will stop breathing. They'll breathe in, breathe out, and then it doesn't kick on to start breathing again, right? So there will be errors in the rhythm of the breathing. And these are more problematic a lot of times, but they are telling you that there's something wrong in the brain with the control of the breathing. In that case, then we're more likely to see significant changes in oxygen levels, and that can be super detrimental to people. They don't feel well, they don't wake up refreshed, and you're not sleeping very well. And then a third can be if we look at occlusive types of problems where we actually, in a lot of our people, we see that this neck becomes really an interesting attack vector in the body, because you've got everything that needs to come from down here to support function of your brain has to come through this neck. So we've got a spinal cord that comes through there. We've got nerves that come through the outsides. We've got blood vessels that go outside and inside, some that go up, some that go down. You've got your trachea that allows you to be able to breathe. So in people where we have inappropriate movement or kinematics in the neck, or just anomalies in the way it's built, sometimes can sleep in a way where it can become restrictive as well, and we can actually affect nerves, vasculature, the breathing itself, the stimulation from, or the CSF flow that changes the way that we're able to irrigate the system. So there can be a lot of things that are affected just from the positioning of your neck in a long period of time. So the same way you might wake up, a lot of you probably wake up every night and you're like, my hand just is asleep every night. And I would be willing to bet that a lot of you are having that same thing that are happening, but it's happening in your brain. It's like your brain is, falling asleep at night, and then you get problems that come from that, especially in the morning. So it's a really good question. It's probably one we should do a little longer conversation on. And Amanda said a video on vestibular dysfunction and proprioception. How do they differ? How do they influence each other? And if they occur? Yeah. We did a pretty long one. Ginia, I don't know if you can throw a link in there. She's ahead of me. Very next thing, if I should have read it. She said, I will put it on the list. Thank you. We did this one. This is the one where we did the 2-part with the paper from the live. It's been a couple months now. But we went through this over the course of 2 lives, that particular problem specifically. So you can go back. I want to say, Gina, I don't know if you remember the title of that one. I'm sure it was amazing. So if you want to put it in there, that would be wonderful. Thrive Crystal Kingdom. I have pot symptoms, and doctor didn't believe me because I have a pacemaker. I am interested to know more about that. This probably isn't the format for it, but yeah, there's probably more to that story, but this is probably not the right spot. Happy to have you reach out if you like. Matheson said, I'd love a video on neglect and vestibular issues after head injury. That's one we probably do. The one we did a long time ago, was it's an older video on YouTube, but it's had quite a few views, where it's about someone who, the title's pretty snappy. It was like 2 weeks POTS recovery, something like that. It's something with 2 weeks, something with the POTS recovery, but that was, I believe, if I remember right, that one was a hemi-neglect case. And then we did a case a couple weeks ago where we talked about different versions, and one of them was a hemi-neglect too. If you want to sink your teeth into that, we can always talk about it deeper. High blood pressure and POTS, that's a very good question. It's a work through just like everybody else, but what it's meaning to say is that the reaction of your body to sustain that pressure, it feels like that's the pressure it should be. Now, whether that should be or not is the question. And then you want to know, is it buffering correctly into the brain, or are we having a difficulty with stenosis somewhere in the vasculature that is forcing that blood pressure high? So a lot of good questions there. Oh, this is a good name. IV fluids help me out a lot whenever I end up in the ER for POTS, but my veins are genetically small, so even with an ultrasound, it takes an hour to find a vein. Our port's worth the risk. Yeah, it sounds like, it helps in a pinch. Yeah, that's not ideal. And our port's worth the risk. I don't know. I mean, you're opening up a different set of risk factors there, and it's hard to know. I can't really be the one to determine what the risk is worth. Apologize for that, but it's like, yes, you are correct. you're identifying what the risks are, um, and that's going to be part of the calculus. How often you need them, and how useful they are. Are there any other steps that are available outside of that help, etc.? So those are things to consider, but I can't make that call for you. Celeste, if it helps, I took a semester to study remotely. Cool. And worked on physical therapy. It helped me so much, and I'm still in school. Good for you. So taking a remote class, it sounds like, maybe help. At Amy, that's hyperadrenergic POTS. Maybe, maybe not. Let's not lump it like that. It's better to look at it like this. Like, it's like, okay, I have high blood pressure. I also have tachycardia, specifically when I stand up. Does it change? Does it not? So, like, does the orthostasis matter? Does the breathing change? Does the CO2 levels change? Does the cerebral perfusion change? Do we see alterations in the breathing patterns? Like, all of those things go together. So hyperadrenergic POTS is basically just a way of saying my body has to crank more, and then I got to spill over, where it becomes not specific to my heart anymore. All of that output that is being generated from the arousal systems in my brain are leaking out into other areas as well, and then I get an overproduction of activity in areas that aren't specific to maintaining blood flow into the brain. So that's kind of that's a way to frame that. Oh, Ethan, could it be there's hypoperfusion in other areas of the body, and that's what's causing those feelings in those areas? I mostly get in the lower halves of my arms and legs, and have been told it's bigger muscle groups they feel it in, but it makes sense that it's getting less blood flow to all the extremities. What alternative therapies? Oh, no, sorry. Yeah, so that's one of the thesis questions is, are we seeing changes in vasculature, endothelial function into these larger muscle groups as well, that are causing that? And as you drive them, is the source of the pain or the fatigue or the discomfort coming from something that is more chemical? That's kind of the typical, like the inflammatory load is kind of what people always talk about. But then also, like, that is the same thing we see with like intermittent claudication, problems that look like changes in perfusion. So I really like where your head's at. Mathias, just rocking and rolling, head on a swivel tonight. I like it. Okay. It's possible that POTS are dysautonomia. I see your question, Mary. Would alternative therapy for autonomic systems, what do you consider an off-ramp? I don't know how to answer that question because we gotta solve your problem. So these are just tools that you could use. I think they're all great tools, but I don't know which one for sure to recommend. Is it possible to have POTS or dysautonomia with a pacemaker? I've been dismissed by doctors. Oh yeah, this is one we talked about a minute ago. Yeah, you got to look into that, whether it's pacing high or whether it's pacing appropriate to blood pressure, and then what was the instantiation of getting the pacemaker in the first place would be really helpful. Do you use Neuro 20 a lot for the autonomic system? It's a tool. So all of these things, Mary, are great tools. But just like if you got I got a barn full of tools over here. And you're kind of always looking to use the right tool for the right problem. Most important part is I know we have names of these conditions. I know we have POTS. I know we have orthostatic hypotension. And I know we've got cerebral hypoperfusion, and we've got all of them. Those are just names. They don't tell us anything about the physiology. So if we want to understand how to fix it, my perspective, and no one else has to work from my perspective, but my perspective is those names aren't as helpful as much as understanding the underlying physiology and like how is it working? How is it working? What can we do to augment the way it works, and can we make that sustainable? So all of those tools are awesome. I use any and all of them, but for some people they're going to be great. But I don't like getting people too hyped on a particular tool because it may not be the right one for them. And we may focus on the wrong part. So I tend to spend more time talking about how do we get to the underlying, and then from the underlying, then we open up the toolbox and say, like, what's going to be the best tool here? Mary, is it safe to have epidural steroid injection for C5-6 herniation if you have other neck issues, cerebral hypoperfusion, sporadic problems with vision and balance? That's a great question. I mean, there's certain risks to that. I would I mean, I don't know a lot about this case. I would wonder if there are other conservative things available prior to the steroid injection, or if that's kind of where you are in the sequela, or if you've had, if somebody could get eyes on you that would allow you to be able to see how all those things are interfacing. That might be useful. Sasha, have you found treatment in your clinic that can potentially decrease the large volume of water and electrolytes people need to drink daily to function? I mean, that's the goal, right? Is to not have to artificially just like smoke the system and keep your kidneys dancing. You're trying to look at how do I. It's this. So a correlate could be you're trying to get your body to be able to detect fluid concentrations correctly in the vascular system writ large, right? So another way to think about that would be you also have other things where your body has to detect something. So if, for example, if I can't detect gravity as well through my left ear, it's going to make me feel like I'm falling in that direction, right? Okay. Or it may make me unstable or unbalanced, whatever. But because I can't feel it, it makes it so my system can't work right because I'm not able to detect where I am on the planet, right? So then the symptom will be that I will be dizzy. I will be uncoordinated. Okay. So if we take that same idea and say, well, how would I solve that? I would solve it by saying, is there enough, can that ear, even though it's not working well right now, does the system have enough integrity to where it can learn again? So if we dose it way down, make it super easy, can it learn how to sense gravity again? And if it can, then I can get back to parity, which will decrease my symptoms and allow me to like do normal things again. So this is the whole concept behind neurorehabilitation and neuroplasticity. Neuroplasticity is the ability for these loops or these pathways in the brain to be able to learn. And another way to think about learning is healing, okay? So the same way we would think about that in your ear, you would think about that the same way with the reflexes around the pressure in your vessels, in your body, pressure of the blood flow through your heart or through your lungs. How is that all correlating with the way you breathe, with the way your heart beats? How is that being transferred into the vasculature in your head? Is it all being moved around in accordance with the way that you are moving and thinking your body? So the same way I can lose function in an ear, also lose function in a receptor, a baroreceptor, let's say, a pressure receptor in my neck that should feel how much blood is flowing through my neck. Maybe it's slow, maybe it's a little weaker, maybe there's too much noise in the system and I'm not able to detect it. Is there a way that we can back out of that and say, give it smaller stimuli that allow it to be able to grow in its function again and to be able to heal? So that's kind of like the core concept of why you would consider rehab or why you would consider exercise. The same way you would if you hurt your arm, you'd want to make it stronger. You have to be able to feel the muscle, feel where things are at so that you can then move it. You have to be able to feel what's going on in the vascular system in order to be able to move the vessels to push blood around. I can't say enough that our body doesn't, even though we get 5 liters of blood flowing around in it, that's not enough to fill up all the vasculature at one time. We rely on our brain and our extended nervous system, our peripheral nervous system, to be able to tell us what is going on with where we are in space. Is my head above my heart? If it is, it means we have to push with a little more force because we got to beat gravity to push blood into the head. But if I can't detect that, or if I can't do it at a good enough rate, then I'm going to see that system fails and then I'm going to get symptoms from it. So that is kind of the underlying concept to why we think about neurorehabilitation, which is a form of exercise, but it's like exercise for your brain, not so much for your muscles. It's for the nervous system. And can you exercise that nervous system so that it is able to maintain a level of output? The same way you want to be able to pick up your kids when you get older. I got to be strong enough to pick up my kids. You hear people say that all the time. You want to be strong enough to be able to pick up your own head as well. And that's kind of the way that we're thinking about it. And to offset it with medications is a way that you're just trying to kind of muscle the system rather than directing it toward the underlying neurology. Okay. All right. Nicholas, the time frame is when we need you to come back. It's different for everybody, but yeah, when it's time to make a change or we have to measure something new, that's usually when we get people back. Cool. Thanks for listening. I don't know where I'm at in the messages, guys, but thanks for hanging with me. I really enjoy the conversations, actually. I'll try to jump back in here. We're doing pretty well. Hope you guys are doing great. Kind of closing out summer, which is always sad in Michigan because we're starting to get cold mornings already. It feels like we just started summer. Now here it comes. Here comes the fall. Okay. Dr. Ginny, I just want to say thank you for finding this video, Pot's Gone in 2 months. This is a two-parter. That one is the one I believe was a hemi-neglect story. If not, I apologize, but it's a great story, so you can watch it. Where did I go? Sorry, I scrolled down for who knows why, and then now I don't know where I am. Okay, Brittany. Oh, so Brittany's asking about, I had mentioned like a weakness in the palate, in the soft palate particularly, that related to apnea. That can be obstructive apnea. But, little inside baseball, with central apnea, where we're having the respiratory generator, right in that same area is actually how we control the elevation of the palate. So a lot of times if that little area in the brainstem in the medulla is having trouble, then we'll see that correlation between pauses in the respiration or disordered breathing, and also see changes in the palate. And they may actually be unilateral, where one side is affected more than the other. And you'll also experience that too. So it's like a double whammy. If that area in the brain is affected, it might affect the respiratory rhythm and integrity, but it also may affect the palate. So you may snore, you may get some of that vibration in the throat, some of that type of an activity when you're sleeping. Good question. Why might you have that? It can be lots of things. So anything from whack in the head brain injury to something viral. We were seeing, interestingly enough, in viral injuries that'll go into one nerve, you can get them into that recurrent branch of the vagus, and we'll see changes in the palate as well. Those are kind of interesting, but those are one-off. But a lot of them tend to be more brain injury, neurodegeneration, especially as you get a little bit older. Once we start affecting dopaminergic outputs in the nigra, a lot of times we'll see them kind of converging on the palate as well. And then as you get further along, people with more frontal lobe problems will notice that the palate may be affected as well. They may also find that they don't swallow as great. Their voice may become raspy. You might notice that like drooling a little bit more. Those are kind of indicators to consider there. Okay. Bella got diagnosed with thoracic outlet syndrome, internal jugular vein dysfunction through ultrasound, CT and MRI, T2-3 out of the left with POTS, neck instability, preload dysfunction of my heart. By an echo, lying and standing. Would you love your thoughts on the best treatment options if I can fix these things? Could POTS improve? Yeah, so it sounds like you got some great things to work on here. And a lot of them are kind of converging on, that area right in there. Now, internal jugular vein dysfunction is an interesting idea. I don't know if it's being compressed or because the function doesn't have a ton of operational function. It's relatively passive, so it's more something occluding its flow rate might be a better way to think about it. But if so, sounds like there's a lot of structural opportunity to be able to solve for this, which is super cool. So I'm looking forward to seeing how this goes. But addressing all that structural stuff would be awesome. And most of it is just like a lot of posture stuff, which is cool. So good luck. I'm super hopeful for that case. Ritvik, thanks in part to your lectures and shorts, I've started doing some at-home physiotherapy, starting with supine exercises to treat POTS long COVID. Thanks for sharing. Awesome. Ritvik, I love it. Love having you. Always great questions. Always rooting for you. So keep rocking and rolling. Hopefully we can help as much as we can. All right. Where are we? Here. So we're at prudence. And then I'm going to slide down here and just see where I'm at. Yeah, Brittany, no problem. Okay, so we got some interesting ones coming up. Oh, Bella, yeah, obstruction, yeah. Awesome. These sound like, I mean, obviously without seeing any of this, I'm just going on off a chat and I'm not giving any specific advice, but these are cases that we usually get excited about because there's a high potential for upside there. So very cool. All right, let me back up here. Okay, there we are. Prudence. Prudence, can you talk about anxiety meds with inappropriate sinus tachycardia? It seems to be difficult to define an anxiety medication for severe anxiety without getting autonomic symptoms after a period of time. Okay. So the overlay that you kind of have in the brain with anxiety and autonomic outputs are in the brain. They're central. So it's where I have a sensation of how alert I should be. And sometimes that level of alertness should come from there is an external sensory cue that is trying to stimulate your body that you should be concerned right now. And then sometimes it's the inability to process where we have changes in the ability to calm that system so it runs too hot. And if it runs too much, it's uninhibited is the more correct way to say that. But if it's uninhibited, it runs hot. And then we're way more sensitive to things that create that alertness or arousal level. And then we get a bleed over where that can feel like anxiety, but it can also display as autonomic outputs because autonomic outputs are the motor activity of anxiety, of fear, basically. Fear, concern, unknown. So that's kind of where those things interface. So the question is it a sensory problem, processing problem? If we're on meds, sometimes meds can change the processing of that and make you change the sensitivity to those things, which may be problematic. So as you're changing the sensitivity to your external state or how I feel about it, you may get an output that affects the autonomic activity with that. So then it's hard to take them apart. In other cases, though, people will have autonomic problems where the body is trying to solve a problem, but in doing so is also alerting your brain that something's going on, and you're going to have that like secondary anxiety that comes with this kind of health-related problem or crisis that you're in. So it's worth paying attention to it from both angles. Okay, Brittany, are certain pillows or towel setups helpful? We're talking about the apnea thing. As someone that's hypermobile, I'm having problems finding anything that works for my neck without affecting breathing or causing migraines. That story is real. So many people. And it's not even just hypermobile people in general. Like this is people that have whiplash injuries, football injuries, problems with their neck where we just have some of that joint movement that is inefficient, and we plot people in a position for a period of time for 8 hours or an hour and a half at a time, then we can really augment that. Is there a particular pillow? I haven't found a one size fits all that really solves that yet. Just a lot of, Brittany, I don't know what your stature is, but it may be different from a 6'5" football player. But the general advice I give is I have found that using a down pillow that has a little zipper on it so that you can control the amount of feathers in that pillow and kind of like puff it up so that it allows you to sit in like what is the perfect posture for you. So you kind of tuck it in, make it perfect for you. That can be better. So ones that are moldable and breathable, but then hold their shape are probably the best. The foam ones you can do that with as well, but they tend to break down a little bit differently. For me, using the down feather pillows seems to be the one I'm the most in favor of, although it's not one size fits all, and somebody will disagree with me, but that's that would be where I would start. And then you're just trying to lock that thing in and stay as neutral as you can. But another side note, so some people will notice that they have a position, like if your neck's jacked up, technical term, but if your neck's jacked up a little bit, you may notice that there's like straight ahead may not be like what makes you feel optimal if it's unaddressed, right? So if you're just flying blind and you don't know what's wrong and you're like, but I'm going to aim for neutral. Some people will find though that neutral is not their best because of the orientation of the change in their neck. They may actually find that like there is a different position where it's goofy, but that's actually where everything runs through the cleanest because your neck's not aligned appropriately, or the function's not appropriate. So some people will find like if you try to put them in neutral, they feel worse. But if I like have my head like this, then that they can breathe and then the blood flows through. And then you want to solve for like, well, now I need all that structure to be normalized so that I can sit normal, I can sleep normal, I can be normal, and have all that everything be aligned and flowing correctly. So two ways to think about it. So if you're just flying blind, you don't know particularly what's wrong, neutral's generally the place to go, but with the caveat that if your neck's jacked up, you might not be able to get to neutral effectively and you might actually feel a little bit worse. Brittany, we were talking about CO2 levels in the blood. And when you're checking those in the blood, you're just getting a quick snapshot. So it's not, I don't love it as much as using the EtCO2 because then I can get a waveform and I can do a thing and I can watch what it does and look at the result. Here you're just getting like a stance in time, but it's very accurate and it's very good to compare to partial pressure of oxygen and then looking at your electrolytes, and you can get a sense of what that pH looks like in the system. Cool. Oh, Bill wants to talk about neck issues at night too. Yep. So hopefully, Bill, that helps you as well. I'm going to leave that highlighted and I'll come down here and see if there's more questions on that. Nice. So true. It definitely feels like neutral causes symptoms in very odd specific positions work. Thanks so much for that. Yeah, that's honestly, when I first started talking about this, I probably wouldn't have thought about that way. My off the head answer would have been just to say, like, try to get to neutral. And I probably have said that a lot. But also we see that in people where neutral is like you watch people on the table, like putting their head in neutral and they just turn into a disaster right there. And then you look at it and they're losing, they're losing saturation in their eye and their breathing gets weird. And then like, oh, I don't feel good. I'm getting dizzy. And then so you got to like find like, oh, actually I got to like turn these vertebrae, and then somebody, oh, and then they relax, right? So that's part of it. But that's where, shout out for my chiropractors in the world, that's where chiropractors, PTs, acupuncturists become super, super, super useful, because sometimes little tweaks like that change your whole life, and it's so dang easy. So I definitely think that it's worth checking out because the barrier of entry is so low. And if you get somebody if you give the testing that helps you understand exactly what to solve for, then that group of professionals is amazing for helping people in this world. Ooh. Oh, Dr. Ginia. Here's an old video. Nice. 7-way neck joints affect brain function. Love it. That's a great one for everyone. Go check that out. Leave us a note while you're there. Say hello. All the YouTube algorithm stuff. Like, I don't know what works the best. If you got to like hit like and subscribe 3 times and leave a comment and then also a thumbs up and a smiley face. Whatever works the best, do that one. And I will be very appreciative of that. How do you treat someone who got POTS after a back surgery? Looked at my whole spine, including neck, and they couldn't find a root cause. It may not be in your spine. That's probably very likely. But it's good you had it worked up, because then maybe that's not the right place to hunt. But also, just because you can't see it in your spine doesn't mean that everything works appropriately. It's kind of like a car. You can have, there's a lot of cars in the junkyard that if you take a picture of them, they look fine, but you go to start them, they don't work. So be making sure that functionally everything runs correctly as well. Brittany, another one wants to say, can you have frequent short of breath related to a loss of cervical curve or stenosis and or POTS while sitting and laying down? Yeah, for sure. That's one of the things people will often note, and one of the can be a catalyst for what we experience as POTS, right? So that's interesting that all these things relate. Yeah, and Mathieson, love the questions. They've been great. Keep them coming. Thrive Crystal Kingdom said, I had bradycardia pacemaker set minimum 60, 120, 60 to 120 range, looks like. It's hard for them to understand because my blood pressure gets crazy, and after years they kind of stared. Stared, believe me, when I went to the ER. I would be really curious about workups around dysreflexia in the system, if the blood pressure is seeing major spike changes too, or if we're getting occlusion somewhere. Those might be good avenues for somebody to run down in terms of problem solving from there. Yeah. How does sleep apnea fit into dysautonomia? What do you do for it? Well, if it's obstructive, remove the obstructiveness. So sometimes people will have to lose some weight. Sometimes using a CPAP is an amazing game changer for people. It's not super great for the love life necessarily, but super great for the sleeping and living life. So there's a trade-off. But then if it's central, then we kind of dig into our neuroplastics portion, the neuro rehab side, and say, can we do things that help stimulate that portion of the brain, get it back running again, and then tie that into what's happening with the autonomic side of that. So breathing is kind of the main generator. What's really interesting is the central respiratory generator, which is what generates that pace of breathing, is like the core drum beat for a lot of the signals that work through the body. It's the core drum beat for the cardiac system. It's the core drum beat for the vascular system. And it is kind of what keeps everything in rhythm. You want it to be all in rhythm, your breathing, your heartbeat, the way you move, the way your vessels move, because it makes it for the most smooth flow rate. Remember, you're taking kind of pressure in and out of your lungs that's going to impact the vasculature in and out of your lungs. They're super delicate little vessels in there. So when you breathe, it kind of opens and closes them like a little syringe, like pulling that blood in and perfusing all those little capillaries in the alveoli and then pushing them back into the heart so they can be distributed. So all this has to be in this really nice rhythm. Like in my mind, I'm picturing like a manta ray floating, going through the ocean. That rhythm helps to be able to keep the blood circulating efficiently, smoothly, keeps the charge correct, keeps the pH correct so that the blood isn't sticking to itself, and it allows it to move smoothly through the capillaries with their charge. So, yeah. Mathieson asks, what kind of orthostatic tolerance would it be if there's a 30 BPM increase in heart rate, which is kind of criteria for POTS. Diastolic levels stay the same, but the systolic levels drop, but less than 20 millimeters of mercury. So that puts you in the range where they're saying, it technically qualifies as POTS, but I find it very interesting because you're looking for the diastolic and the systolic to have a little bit of compression, but if the systolic is dropping, you want to actually look at the waveform to see what that spike looks like. We do it in the Doppler, but looking at that spike will tell you what the resistance is like. So if there's super high resistance in the system already, then you'll find that it'll kind of come up, and then rather than have a nice kind of consistent slope coming out of that, it'll have a sharp peak down, which means that there's more peripheral resistance in the system. Then that becomes the problem you want to solve for. Is something obstructed? Is it getting kind of kinked off? Or are we having problems with the elasticity of the vessel, so they're too rigid, and there's too much resistance? Or are we seeing there's edema or swelling that's creating resistance? Kind of what's going on in that case. Cool. All right. Hi, Christy Lee. Good to see you. Brittany asked, it's a good question. Can neuro rehab send you into post-exertional malaise if you have ME/CFS? How can you prevent it from while doing that, or PT? Yeah, it's a good question. And to some degree, you're probably going to have some PEM. But what you're trying to do is manage the stimulus into the neurological system that allows you to be able to hit a minimum effective dose. So it's like, I got to get it just enough to where we have this genetic change starting to create. We're changing the intracellular structure. We're making a change in the system, but not so much that we're overrunning it. So you're really trying to work within, in our field, what has been dubbed metabolic capacity. So like, what is the capacity of that cell to do work? You're trying to just goose it with enough stimulus to wake it up and make it grow without doing so much that you kick it in the teeth and then you actually injure the cell and it makes it harder for it to grow. So that's the needle you're trying to thread, which is difficult, which is why we use so much testing and objective data, because we're trying to keep it in that tight range so we can keep people moving. But we do walk a line because we're trying to move quickly, where people will have some of those experience, and we're trying to just ride that system through. Because more than likely, as you're trying to get stronger, like post-exertional malaise is really hard to differentiate from just like post-exertional growth. I mean, those are kind of two sides of the same coin. So in some ways, we start kind of flipping people's headspace to start to chase a little bit of it again, almost like when you're working out to chase the soreness. But it's almost like we're trying to help people move through that in a way where we're understanding, is this a negative effect, or are we moving in a positive way? We try to think less about like the subjective parts, right? So like if I'm working out, there are days that are good days and bad days, but if I still get the workout in, it still counts and it still will make me stronger. And so there's some amount of that comes into play as well, where we're just trying to keep, like, objectively, does this system get stronger and stronger and stronger so that we can reduce some of that PEM going on. But it's not easy, and we try super hard to make sure that we're not pushing people too hard, but we have to push them enough to make it work. Can you have a heart attack and then get a diagnosis of POTS from that heart attack? Not from the heart attack. Actually, the POTS diagnosis, part of the criteria is that there's not an underlying cardiovascular problem. So in a heart attack, if we've got where we've kind of cut blood supply to the heart for a period of time, you may have some dead tissue in the heart that changes cardiac output. So it has to work, it has to pump more frequently to get the same level of output. And especially in the early days after the heart attack, you're more likely to have that higher output as well. So good question. Okay, let's see where we are. Ooh, prudence. The anxiety meds often cause delirium, uneven pupil dilation, nausea, blood pressure, crashing. Ugh, I'm sorry to hear that. Yeah, that makes it tough. He says, thank you, I appreciate you. The real MVP, such a heart to help some people. Thanks for being in it with some peeps. Thanks, Megan. Christy Lee, with dysautonomia, why are electrolytes usually so low in the blood and difficult to maintain in an optimal range even when we supplement and hydrate? It's a good question. Some of that may be due to the hydration, unfortunately. And then you want to look at like actual kidney function and making sure that we're not blowing out the filter system. But yeah, honestly, in a good system, if I think about my grandfather lived to be 93. And like, he wasn't carrying around a Yeti with a half gallon of water in it every day. He would have like, a glass of water. Like, if you look at these guys, like, they don't drink a lot of water like we see people doing now. So ideally, like your body, the more efficient it runs, the less it needs that. If we're finding that we're supplementing the ability to direct blood flow effectively, to control circulation, if we're supplementing that with volume, then we're going to create some of those issues around electrolytes because we're asking that system to maintain a different ion concentration. So that part's tough. And we'll actually see that the shift of pH starts to change, and that'll also change electrolyte functionality because of the bicarbonate and ionic shift that's going to occur. So we do actually have to be a little more. I think you really touching on a good point, because we kind of recommend electrolytes like as much as you want, go hard. But also when you start doing that over a longer period of time, you start actually, changing the affinity for other trace minerals in the system. And then we start to get breakdowns in some of the way that we make certain enzymes, or we make certain certain transmitter systems, and then we start to get this cascading problem. So I think that touches on a really important point. It's like over time, like we don't know a lot about that. Like you guys are the people that are like leading the charge. You are the ones that know this better than the researchers, because they haven't researched it before. So you're like experiencing it on the front end. And that's kind of one of the things that we've been seeing, is that over a long duration of using electrolyte supplements, that you start to see breakdowns in other parts of the system to try to maintain that. So it's a really good question. Okay. Yeah, no problem, Brittany. Happy to help. Mary, thanks for answering about steroid injections. Probably overthinking it. Looking forward to come back. Yeah, for sure. What can someone do at home to help get blood and oxygen pumping up to the brain? Moving. I mean, that's the general answer. I don't like to give them. I like to be specific, but moving well. That's what the whole thing's built on. What if someone feels more clear-headed when they're in their slouched posture? I always hear the advice that slouching could obstruct blood flow and that people should stand up straight, but doesn't that apply to people who feel more lightheaded when standing up straight? This is a common thing. People out in this chat that have made this observation as well. Yeah, but it's kind of like what we were talking about with sleep. Like if we've just built the structural thing where this like slouchy is the most advantageous position. It gets your head down to your heart, so you're not pumping so hard. It doesn't cause any problems, but then that's what you're limited to. Whereas what you're saying is like, this is jacked up enough to where this is the best I got. I'm not able to get there without it creating its own problem. Same as like the neutral position sleeping. So these are good opportunities for structural people to get their hands on you and get you straightened back out, train you back up again. Okay. Let's see. So the next one was, we're kind of back on the pacemaker for Thrive. They're saying the tilt table is not effective only if you're only measuring the heart rate, but I would argue that that's not the most important part of a tilt test. The heart rate is the lagging indicator. The leading indicators are going to be blood pressure, cerebral perfusion, and carbon dioxide ratio. So I would actually be focused on that. All right, guys. Look at us go. Someone dealing with hot smells. There's 2 weeks IV fluid soon. Yeah, you want to try to understand. The mouths, you want to see, does it change also with changes of the orientation of the lumbar vertebrae as it's coming through the diaphragm? Hopefully they did that and kind of put you on a bolster and check and make sure that that's not a postural related thing as well. Let's see. Why would rotating one's head to the left and right in a pool cause less symptoms of dizziness than rotating one's head in the same way outside of the pool? Is the buoyancy alone enough to make a difference? It can. It can. I think Ginny, did we post this video today? We talked about being in a pool. Being in a pool is amazing for people that have problems with control of their blood flow because it works like volume expansion just from the outside in. Gives you a nice big hug, squishes all that blood, puts it up in your head. Oh, feels so good. And that can be really useful for people with POTS. So we know if it's a perfusion problem and you turn your head and it's a little easier, it's helpful. It gives us signal, right? And another hot tip that we notice or that we find in people is if you have more of a vestibular problem or more of a proprioceptive problem or a problem where you don't know where you are, then being in a pool and moving around and like having that change in gravity can make people feel super gross. So it's nice to be able to compare and contrast that. It's like, how do you feel in a pool? I hate it. Well, that's an indicator where if you're like, no, I love it, then that tells us something different. So it can become pretty diagnostic in that way. Cool. Yeah, Melissa's question about the low blood pressure, it doesn't really matter if you think about it in terms of POTS or another dysautonomia. The problem, to describe it as what it is more helpful. So hypotension is the thing that you're solving for. And the hypotension obviously comes with being able to make sure that you're able to trigger that motor system, right? So if we've got some faulty motor system control systems, then it's also going to affect that blood vessel underneath, which makes it more relaxed, which decreases that blood pressure. So kind of what we talked about earlier with that, with the neglect type of activity. Cool. Hopefully that helps. All right, guys. Okay. I loved it. I'm also tired. So I'm going to use this as an opportunity to bid you all good night. It's great being back on the live again. I missed 2 weeks, which doesn't make me feel good. But to be fair, one of them I was flying, and the other one I was there and did make a video. So technically I kind of did it. But I'm super happy to be back. I'm liking getting to answer your questions. You guys answer great questions. Next week, we'll probably introduce a new concept. You guys gave me some ideas tonight. Maybe we'll put some of those to work. And we'll just try to keep bumping up our knowledge base. And hopefully that translates for you guys into some help, into some improvement in how you're feeling and how you're doing. So have a great night. Thanks for being here.